Hello everyone, welcome back to my channel. So in this video, we are going to discuss about the triple phase CT protocol. So in this video, we'll discuss about the triple phase CT protocol. But before that, let's discuss the basics. Okay, so basically, liver has dual blood supply. Okay, liver has dual blood supply via, and that too, and we are talking about the oxygenated blood supply. The dual blood supply is actually via the portal vein and the hepatic artery. Portal vein is the main oxygenated blood supply that counts for approximately 75 to 80% of the blood supply, and hepatic artery blood supply is for about 20 to 25%. Okay, portal venous blood comes via the gastrointestinal tract, and the hepatic artery takes the oxygenated blood from aorta. Okay, so here comes one clinical implication, that when the portal vein is carrying the oxygenated blood from gastrointestinal tract, cases of amoebic colitis, amoeba gets transferred to the liver and thus is responsible for the liver abscesses, amoebic liver abscesses. So here comes the portal venous blood supply from the GOT. And another thing is that whenever there is portal hypertension, the pressure between the portal vein is very high. So it cannot take blood from the gut to the liver. So what happens? There is instead retrograde flow. So in this case, to supply the needs of the liver, the hepatic arterial flow increases, and so the hepatic artery becomes hypertrophied, and also the hypervascular neoplastic lesions of liver, for example HCC, take their blood supply from hepatic arteries. Okay, keep this in mind, because that's very important when we discuss the triple phase CT protocol. Okay, so triple phase CT protocol is done to characterize the focal liver lesions, hypervascular metastasis, endocrine tumors. Okay, so what happens? The main thing is the attenuation difference. Okay, so as the percentage blood supply of liver is lesser from hepatic artery and more from portal vein. Okay, but the liver tumors take their majority blood supply from the hepatic artery. We all know that a lesion is visualized only because of the attenuation difference between the lesion and the background parenchyma. Okay, so the majority of the liver tumors like HCC gets its supply from the hepatic artery, but the liver is mainly supplied by the portal vein. This difference in blood supply forms the basis for the triple phase CT. For example, in the late arterial phase of triple phase CT protocol, okay, late arterial phase, the HCC tumor, for example, enhances a lot. Okay, like this is the lesion and it is enhancing a lot, and the background is not getting supply from hepatic artery but portal vein, so it remains slightly lesser. So this lesion stands out brighter in a background of darkness. Okay, similarly in the portal venous phase, this HCC, because it's a tumor with poorly developed capillaries, so it loses contrast very rapidly. So okay, so again the tumor has lost its contrast, but the background liver, as it is supplied by the portal vein, enhances brightly. So again this lesion is visualized because of the attenuation difference, a darker lesion in a brighter background. Okay, so this difference in attenuation leads to the visualization of lesions. Dark lesion in white background, or white lesion in dark background. Okay. So, for example, also the hypovascular lesions like metastasis, the hypovascular lesions, they become evident in the portal venous phase because all the liver is enhancing, but these tumors, for example, the hypovascular metastasis, cysts and abscesses, they don't have much supply. They become like they appear darker in a white enhancing background. Okay, and that's the basis of triple phase CT. Okay, so now let's discuss the triple phase CT protocol. So first is the non-contrast CT. It is taken whenever, actually it is always taken, for example, to look for any calcification within the lesion or any fat in the lesion, best visualized on NCCT images. The first phase of triple phase CT protocol is the late arterial phase, that is taken at like 35 to 45-second post contrast injection delay, the late arterial phase. Portal venous phase taken at 60 to 75-second post contrast injection delay, and delayed phase is taken at 2 to 5 minutes delay of after injecting the contrast. At some places, these are the variations written like 35 to 40 seconds, 70 to 80 seconds, 3 to 4 minutes. Okay, but just remember these values: 35 to 45 seconds, 60 to 75 seconds, and 2 to 5 minutes. The patient position is supine with the arms lying above the level of head. Scan extent is from the diaphragm to the iliac crest, and the scan direction is craniocaudal. Okay, what volume of contrast you will give to the patient? It is usually 150 cc through a 18 gauge cannula at the rate of 5 ml per second. There are variations also, like according to the weight of the patient, less than 75 kg, then 100 cc of contrast, 75 to 90 kgs of patient, 120 cc of contrast, and if the weight is more than 90 kg, then 150 cc of contrast. Okay, this flow rate of contrast injection is according to what cannula you are using. Like for 18 gauge cannulas are usually used in the triple phase CT. The contrast rate is 5 ml per second, but if the cannula is like 20 gauge, 3 to 4 milli per second is the rate of contrast injection. So usually 150 cc of non-ionic contrast through 18 gauge cannula at the rate of 5 ml per second. The scan delay we already have discussed: 35 to 45 seconds, 60 to 75 seconds, and 2 to 5 minutes delay. Okay, these are the time frames for the CT technician. By looking at the images, how can you say that this triple phase CT is done correctly? Okay, so in the late arterial phase, you will see the enhancement of arteries like the hepatic arteries, but also there will be some enhancement of portal vein also. If there is enhancement of arteries only, then this is not the late arterial phase, but it's the early arterial phase. For liver lesion characterization, this early arterial is not recommended. That is taken at 50 to 20 seconds post contrast injection. In the early arterial phases, HCC don't take contrast and they don't appear hypervascular. You can miss these lesions. Instead, early arterial is just used for looking at the arterial anatomy, for example, before the liver transplant. Okay, so late arterial is identified by enhancement of hepatic artery and some enhancement of portal vein also. The portovenous phase, okay, how to look these? The portal vein will enhance and there will be some enhancement of hepatic veins also. In the late arterial, there should not be enhancement of the hepatic veins, but in portovenous phases, both these are enhancing. Okay, and in the delayed phase, there will be some enhancement in the portal vein and the hepatic veins, but that won't be as much as in the portal venous phases. Okay, so for example, these are the hypervascular lesions, the HCC, FNH, adenoma, hemangioma. We'll discuss these later in our liver series. The hypovascular lesions, for example, metastasis, cysts, and abscesses. Another category is the fibrotic lesions. Uh, why they are important? Because they have fibrosis within them, and these fibrosis accumulate contrast in the delayed images. So 10-minute delayed scan is taken where they pool the contrast and their visualization becomes more easier. For example, cholangiocarcinoma and fibrotic metastasis. Okay, so I think this triple phase CT protocol uh, is like has become easier for you. And now let's catch you in the third episode of this liver series. Okay, thank you so much.